Hello.
Good morning, everyone. Today I am going to present student CPC from the Department of Obstetrics and Gynaecology. Our patient was a 50 years para-2 living to postmenopausal female, homemaker and resident of Rishikesh. She presented with complaint of pain lower abdomen for 3 months associated with heaviness in lower abdomen. It was insidious in onset, dull aching, moderate in intensity, non-radiating, with no aggravating factors and reduced on oral analgesics. There was no history of abdominal distension, no history of postmenopausal bleeding or vaginal discharge, no history of early satiety, loss of weight or appetite, no history of hematemesis and melena, no history of chronic cough, chest pain, breathlessness, hemoptysis or fever, no history of urgency, increased frequency of micturition or burning micturition, no history of headache, dizziness, loss of consciousness or bone pains. She presented to Aiims Rishikesh, then her history was reviewed and she was further evaluated. She had attained her menarche at 13 years of age and she was postmenopausal for 5 years, her previous cycles being regular with average flow, and her perimenopausal transition was smooth. There was no history of postmenopausal bleeding. She was a para-2 living to female with previous 2 normal vaginal deliveries and her last childbirth was 26 years back. There was no history of contraceptive usage or no history of ligation. She was a known case of type 2 diabetes mellitus on oral hypoglycemic agents for past 3 years. Recently diagnosed hypothyroid on tab thyroxine 25 microgram with no other comorbidities and no significant surgical history. Her family history was not significant and no history of malignancy in the 3 generations. Her sleep and appetite were adequate and bowel bladder habits were normal with no history of addictions. Moving on to examination, patient was conscious, coherent, cooperative, well oriented to time, place and person with an ECOG performance score of 0. Her general condition was fair. There was no pallor, icterus, cyanosis, clubbing or lymphadenopathy. Breast thyroid examination was normal. Her vitals were stable and CVS and respiratory system examination within normal limits. Her BMI was 25.6 kg per meter square. On per abdomen examination, umbilicus was central inverted, abdominal obesity was noted, there were no scars, sinuses, visible pulsations, and hernial sites were intact. An approximately 15 into 10 centimeter firm to hard non-tender abdominal pelvic mass was felt in the left iliac fossa with restricted mobility and lower border was reached and there was no ascites and no other palpable organomegaly. On per speculum examination, cervix was posterior and there was no discharge and vagina was healthy. On per vaginal examination, cervix and vaginal examination was normal. Left fornix was full and the same mass was felt through the left fornix, while the right fornix was free and non-tender. On per rectal examination, rectal mucosa was free, mass was felt high up and rectovaginal septum was free. So with this clinical findings and history, we had differential diagnosis of ovarian tumors, most common being benign cystadenomas and followed by baseline history fibroma and mature cystic teratoma. Other ovarian tumors could be borderline ovarian tumor or malignant. Our second differential was fibroid, which could be subserosal or pedunculated or a broad ligament fibroid. There could be non-gynecological presentation of pelvic masses, which could be a urachal cyst or peritoneal inclusion cyst. However, patient had no other GI or urological complaints, so we had ruled non-gynecological differentials. So on investigation, her hemoglobin was 12.8 while other parameters being normal. Her PT-INR, liver function test and kidney function test were within normal limits. Viral markers were normal, serum TSH was 5.6 and chest X-ray and ECG were within normal limits. So we evaluated her tumor markers. Her LDH was raised, which was 523, while rest of the tumor markers including CA125, CEA, CA 19.9 and AFP were normal. She had an outside ultrasound report which was suggestive of uterus measuring 6 into 4.5 into 3 centimeter with an endometrial thickness of 3 millimeters and no focal lesion in the endometrium. A well-defined hypoechoic mass of 9 into 7 centimeter was seen in the left iliac fossa extending to the left adnexa with no significant internal vascularity, and left ovary was not visualized separately, right ovary was atrophic, and no free fluid in the peritoneal cavity in pelvis. CCT scan of abdomen and pelvis revealed a large lobulated solid mass lesion of 12 into 10 centimeter in the left hemipelvis extending to the left iliac fossa with heterogeneous post-contrast enhancement with few non-enhancing internal areas. Left ovary was not seen separately while uterus and right ovary were normal, and there was no evidence of ascites or retroperitoneal lymphadenopathy. Visualized vertebra showed early degenerative changes. She had an outside MRI report which showed a large lobulated solid cystic mass of around 12 into 10 centimeter in the left lower abdomen, again in the left iliac fossa. Left ovary was not seen separately. The mass lesion was iso-intense on T1 weighted imaging and hypo-intense on T2 weighted imaging. The endometrial thickness was normal, uterus and right ovary were normal. So based on the imaging finding, we ruled out our differential of fibroid as it was an ovarian mass. So I'll further discuss the differentials. Ovarian cystadenoma, which comprises of around 2/3 of all the ovarian neoplasms. So for this patient, the point supporting this differential was there was no ascites, no loss of weight or appetite. Tumor markers were normal apart from LDH, which is a germ cell marker for dysgerminoma predominantly. And there were no bowel bladder complaints. Points against this differential were patient was a 50-year female, she was postmenopausal, there was a large solid cystic adnexal mass which had restricted mobility on examination. Our second differential was fibroma, which constituted around 4% of all ovarian neoplasms. Points in favor were it was a unilateral and a solid mass on CPC and ultrasound, and the female was a postmenopausal female. Points against were there was no history of loss of weight or appetite and no history of early satiety. Our other differential was mature cystic teratoma or dermoid cyst, which generally comprise 20% of ovarian neoplasms. Points in favor were it was a unilateral mass, however few, around 10% could be bilateral. There was no ascites and no loss of weight or appetite. Points against were the female was a postmenopausal female, it was a predominantly solid mass with restricted mobility, and dermoid generally has characteristic imaging features on ultrasound and CCT which were absent in our patient. Borderline ovarian tumors comprise around 10 to 15% of all the ovarian neoplasms. Points in favor were a 50-year postmenopausal female with a large solid cystic adnexal mass, and the symptoms were present for around 3 months. But patient had no GOF symptoms, no history of loss of weight or appetite, and she was a postmenopausal female. Other differential was a malignant ovarian neoplasm, which comprise around 20 to 30% of the ovarian neoplasms. Points in favor were a postmenopausal female with a large solid cystic adnexal mass. However, the characteristic features of ovarian neoplasm were absent, which are ascites, loss of weight or appetite, bowel bladder complaints, and early satiety. And based on the imaging, we had already ruled out our differential of fibroid uterus. So, with the provisional diagnosis of a 50-year female para-2 living to with a postmenopausal with complaint of lower abdominal pain. So, we planned her for exploratory laparotomy, total abdominal hysterectomy, bilateral salpingo-oophorectomy, along with frozen section, and further plan to be decided. So, on exploratory laparotomy, there was a 15 into 10 centimeter left adnexal mass with the normal fallopian tube. This mass was adhered to the sigmoid colon, small bowel loops, psoas muscle, and to the lateral pelvic peritoneum. Left salpingo-oophorectomy was done, and the mass was sent for frozen section, which revealed suspicious of malignancy. So, we proceeded with completion surgery total abdominal hysterectomy and right sapling oophorectomy, along with infracholecommentectomy and bilateral pelvic and paraortic lymphadenectomy. So to discuss the pathology part and reveal the diagnosis, I would like to call upon Dr. Kavya. Yes, before moving on to the pathological aspect.
No, better. Comments from the house. Please ask for the possibilities on clinical protocol.
Ma'am, I would like to tell a few points about the clinical findings. This patient had a diagnosis which was mostly suggestive of a benign ovarian tumor, and that is why an upfront surgery was planned. All the clinical features, as we discussed, were suggestive of a benign ovarian tumor, but when the surgery was actually performed and it was suggestive, the frozen section suggested of malignancy, we proceeded. But the idea behind discussing this case today was that the findings, the final the diagnosis was only possible by a histopathological evidence. All the clinical features which we had suspected pre-operatively based on the basis of clinical examination and radiological findings, they were suggestive of an epithelial tumor, possibly benign, but the final diagnosis changed on the basis of frozen section, and that is why we are discussing. So I would like to invite Dr. Kavya to discuss the histopathological findings.
Please ask others to make comments on clinical possibility.
Okay.
Then
I would also like to request the faculty members to give their comments. Yes. Comments from the audience.
you are a pathologist yourself. I hope you don't know the diagnosis.
No. I know a little bit about it, but coming to what we have seen in the radio images which you are saying, it looked like a solid tumor. And what we usually think when it's a solid tumor, we think in favor of malignancy actually. Okay, and another thing is I would like to ask why infection was ruled out. Or didn't you think of an ovarian mass? I mean, it's an ovarian mass, tuberculosis, or two ovarian mass, that kind of thing. Whether that could have been also a possibility. Another thing is when it's a solid tumor and solid cystic tumor, it's more in favor of a malignancy, except fibrothecomas. And the age is 50 years, so borderline ovarian tumors could have been considered as one of the...
Borderline has been kept as a possibility.
Okay, what about the tuberculosis part now?
Ma'am, she had no constitutional symptoms, and it was a well-defined encapsulated mass, which was also a similar findings on examination also. So the diagnosis of tuberculosis was considered lower down, and there were no biochemical features also. And plus, she had no constitutional symptoms of weight loss, loss of appetite, fatigue. All these things were absent. It was a well-defined solid cystic mass, so we considered the possibility of malignancy. And plus, CA125 was absolutely normal. It would have been slightly increased in case of a tubercular mass. In this case, it was completely normal. Except for the LDH, which was elevated, it was mostly the tumor markers as well as the biochemical and hematological parameters were normal in this case. Shall we begin with the histopathological part?
So one clinical point, I think, so masses arising from pelvis, on clinical examination you saying that a lower border was reached. So I was a bit confused. You Your slide mentioned that lower border was reached, and you also said it was not reached. So there's some confusion on that part. The classical teaching is that masses which arises from pelvis and growing into abdomen, you cannot reach at the lower border. And second, how will LDH really help you? What tumor marker, where does it leads you in your differentials in terms of ovarian or GI malignancies?
So LDHs are raised in case of germ cell tumors, and they are also raised in sarcomas. And regarding the lower border of the margin, it is very common that if an adnexal mass has got a large pedicle, so it could be palpable as the lower border would be palpable. If an ovarian mass has got a large pedicle, then we can well palpate the lower border. In that case, it is palpable.
Again about the LDH, LDH is also elevated in lymphomas.
Radiologically, what was the inference in this, whether this is a benign or a malignant mass, both in the USG and the MRI?
So it was a complex mass, so the possibility of malignancy was always there. But since the neighboring and the adjoining structures were free from the mass, there was no infiltration to the sigmoid colon and the adjoining structures, so we considered a possibility of benign also. But anyway, such a large complex polycystic mass of this size, the possibility of malignancy has to be considered.
Postmenopausal woman, solid cystic mass on ultrasound or CT scan, first possibility is malignancy, irrespective of whether CA125 is normal or elevated, because in many cases you may have normal CA125. Second thing is LDH. Higher LDH basically, there is very non-specific. It rises in many situations. It in reference to tumor, it just gives you a tumor burden basically.
Ayush, would you like to add something?
Ma'am, we had provisional diagnosis of malignancy. That's why we had planned her for frozen section. So she was initially planned for a total abdominal hysterectomy and bilateral salping oophorectomy and a frozen section. And depending on the frozen section report, we had planned to proceed.
I don't know, the student CPC, why the students, residents are not participating. It's a very good discussion that is happening here. I would have loved to see more of you people attending it and asking questions. There are certain definite points here to be seen that the classical teaching is any lump arising from pelvis, you cannot reach the lower border. Don't deviate from it. Exam will be at your body. So always go in favor of an abdominal lump if the lower border is reached. Pelvic lump is the lower border is not reached. Second thing is, if we have planned, if you have thought of it as malignant, why was the metastatic workup was not done before the surgery?
So the CT thorax was done, which was clear. Only then she was planned for an upfront surgery. There was no evidence of any radiological metastasis.
Is there any way we can do a tissue biopsy before the surgery to know whether it is malignant or not?
So routinely, when on the basis of clinical, radiological, as well as on the basis of tumor markers, if we find that the mass is resectable and primary cytoreduction, the mass can be removed by primary cytoreduction, we routinely don't perform biopsies. So the biopsies are only performed in which we think that we are not able to achieve complete cytoreduction. Only in those cases we proceed with a biopsy when we have a plan of neoadjuvant chemotherapy. In this case, we had planned an upfront surgery because the mass on the basis of clinical and radiological examination seemed to be resectable, so we proceeded with an upfront surgery. And of course, we had got the facility of frozen section, so we proceeded with an upfront surgery.
Frozen section is more of a plus-minus situation in diagnosing, confirming malignancy on table. It's about 70% positive, and especially in very good centers also. So we pay more stress on pre-operative diagnosis, how far we can reach. I have a small query here regarding the CT scan report or whatever MRI radiological report. Was any attempt was made to rule out a GIST a gastrointestinal stromal tumor. And I'm a surgeon, that's what I'm looking at, because I thought the whole project was going on towards the gynecological side. So I was just thinking did we think of that?
So, GIST are rarely found with such presentations.
No, they're very commonly found with such presentations.
Rarely found with us.
Because it has gone to you, so that's what, the forum is open, so we have to have a diagnosis of an abdominal lump, not is gynecological or surgical or whatever. And that's why the input from the surgeons, or for that matter the radiological discussion, should have also included this thing. Because radiology is very important in the present day. Although we talk about clinical and all those things, without that radiology we cannot go ahead much. Thank you.
Yes, ma'am. Usually we don't see much of GIST, but there were no bowel bladder complaints. Imaging was suggestive of an adnexal mass, and left ovary was not seen separately. So these are characteristic findings pointing more towards the left ovarian lesion. So we did not.
Probably just say that the ovary was not separately seen.
Yes, sir.
This can arise not only from GI tract, but from mesentery also.
Dr. Kavya, please.
Good morning. I will be presenting the histopathology part of the case. We couldn't find the form because this case was done last year during the COVID time and the form has been misplaced. But we had received a specimen of total hysterectomy with bilateral salping oophorectomy along with omentum and the regional lymph nodes. Regional lymph nodes including para-aortic and the right and left pelvic lymph nodes. So grossly, it was a 12 into 9.5 into 6 centimeter mass. It appeared capsulated, there was no breach with nodular surface. On cut section, we couldn't appreciate any cystic areas. It was a completely solid mass with which appeared fleshy and had necrotic areas with hemorrhage. Necrotic areas will be able to tell by the friability of the mass. When we touch it, breaks easily. And there was attached fallopian tube along with this. So first we had received the frozen section. This was just the mass, that is the left ovarian mass. On frozen section, this was the frozen section photomicrographs. Sorry for the color, but as we can see, this is a highly cellular appearing area, and this is a low power view where the spindle cells are arranged in interlacing fascicles and bundles. These are the interlacing fascicles and bundles. And in high power view, if we can see here, these are the large atypical bizarre appearing nuclei along with these spindle shaped highly pleomorphic cells that are arranged in interlacing fascicles and they are running in bundles. So in frozen section itself, we gave a diagnosis of leiomyosarcoma. Further, after the frozen section, when the final mass was processed, that is formalin fixed tissues were examined. This is a low power view of the mass again, showing there are no normal ovarian stroma or normal ovarian components noted. Normal ovary will have follicles and the normal ovarian stroma can be appreciated. But here we can't appreciate any of it completely. The ovary is completely replaced by the mass itself. As you can see, it's highly cellular and there are these spindle cells that are running in bundles and interlacing fascicles. This is a low power view. Now going to the high power view, and we can see that these cells, these are the tumor cells and they exhibit cellular atypia or pleomorphism. When we mention the word pleomorphism, we mean there is variation in size and shape. As we can see, there are spindle cells, there are little oval cells, and they are of different size. This is very small, this is very big. And coming to the other features of any malignant cell is that they will have irregular nuclear contours, and the chromatin pattern will be non-uniform. That means this appears hyperchromatic, this appears vesicular. There is no uniformity in the chromatin pattern. So we can appreciate very large, bizarre-looking cells and spindle-shaped cells running in interlacing fascicles. Apart from this, we were also able to appreciate a mitotic count of about 10 to 12 per 10 high power field. So, and this is the microscopic picture where we can see the viable tissue, where the nucleus can be appreciated, and this part demonstrates the necrotic area. This is referred to as coagulative necrosis, as we can appreciate the cell borders of the tumor cells. So these three features, that is cellular atypia, marked pleomorphism, high mitotic count of about 10 to 12 per 10 high power field, and the classical architecture of interlacing fascicles and bundle arrangement of spindle cells with coagulative necrosis was highly suggestive of leiomyosarcoma. That is, based on histomorphology, it is leiomyosarcoma only. This is the picture showing the mitotic figures. These are the mitotic figures, and these are referred to as atypical mitotic figures. Typical is when they are bipolar, that is, the mitotic spindles will be seen at the two ends of the cell, at the poles of the cell. Here we don't see it, we see it to be in the center, and it has multiple poles. It appears to be star-shaped. So these are all the mitotic figures. These are all the mitotic figures. So that was the microscopy, which was very much suggestive of leiomyosarcoma. Apart from that, we saw that the mass had an intact capsule, and when we say leiomyosarcoma, we tend to think that it could be metastasizing from another primary site. Before we could conclude it as a primary ovarian leiomyosarcoma, we also did check the uterus. The uterus was absolutely clear. The myometrium was unremarkable, and endometrium showed cystic glandular atrophy based on our age. Cervix revealed only chronic cervicitis. Right ovary and tube were also unremarkable. Omentum was free and no lymph nodes were involved. Also from the radiology, we already know that there was nothing involving the retroperitoneum or the GI tract. So this is when we could give the diagnosis of primary leiomyosarcoma. But apart from, this was based on the microscopy, but if we look at the gross, the yellow appearance, solid mass, and according to her age, we can also consider sex-cord stromal tumors, which will have the same morphology. With respect to her age, adult type granulosa cell tumor and thecomas, even though thecoma is a benign entity, so we can rule that out. But these are the DDs that we would like to consider. Epithelial tumors were completely ruled out at the gross examination itself because there were no cystic areas at all. There were only completely solid areas. Carcinosarcoma was also ruled out because we couldn't find any epithelial component. We processed the entire tumor because we had to rule out these entities. So there was no evidence of any epithelial component. So carcinosarcoma was ruled out. And no evidence of metastasis as uterus was clear and there was no radiological evidence of retroperitoneal or GI tract involvement. So ovarian tumors, as we all are aware of, are broadly classified into 4 categories. Germ cell tumors, epithelial or surface epithelial tumors, sex-cord stromal tumors, and the metastatic ones. So this is a normal ovarian ovary, the surface epithelium being the extension of the peritoneum, and this is the cortex showing all the follicles with the oocytes. This is the stroma. Ovarian stroma is a specialized stroma with spindle-shaped cells and smooth muscle cells and collagen bundles. And this is the medulla where the vessels are situated. So as we are all aware of, germ cell tumors includes dysgerminoma, teratoma, embryonal carcinoma, choriocarcinoma. This is not considered considering her age. Epithelial was ruled out at gross examination itself, and these are the entities under epithelial. Sepscotch tumors, as I told, thecoma could be one of the DDs, but it's a benign entity. It will not have as high mitotic count as we have seen in leiomyosarcoma. It will not show any necrosis. And metastatic possibility in ovary could be from GI tract, it could be from breast, it could be from pancreatic or biliary tract as well. So coming to leiomyosarcoma. Leiomyosarcoma is a soft tissue tumor. It's a tumor of malignant tumor of smooth muscle cells. It comprises of about 1 to 2% of uterine malignancies, majority occurring in postmenopausal age group, which is the most common soft tissue sarcoma. Out of the soft tissue sarcoma, it comprises of about 10 to 20% of the cases. The most common locations being uterus. Apart from that, in GIT, it could be stomach, intestine, retroperitoneum, large blood vessels, and skin can also be the site of leiomyosarcoma. The histological types are spindle cell type, epithelioid type, and myxoid type. The diagnosis can be purely based on morphology, where the cells will have typical architecture of that is, the spindle cells will have a typical pattern of interlacing fascicles and bundles. They will have marked cellular atypia or pleomorphism and mitotic index of about 10 per 10, more than 10 per 10 high power field associated with coagulative necrosis. Coming to ovarian leiomyosarcoma, it is said that incidence of ovarian metastasis in uterine leiomyosarcoma is about 2 to 5%, but primary ovarian leiomyosarcoma constitutes about 0.1%. However, even though it's a rare tumor, there is enough literature evidence available to suggest the same, that it can occur as a primary tumor of ovary, exhibiting the same features as seen elsewhere. So we can do some immunohistochemistry like desmine, HCAL, desmone, and smooth muscle actin, but these IHCs also come positive in the benign counterpart, that is leiomyoma. So only based on histomorphology, that is presence of high mitotic rate and coagulative necrosis and cellular atypia, leiomyosarcoma diagnosis is being given. These are my references. Thank you.
Thank you very much.